Moving on to what does traction do for these conditions that we just discussed? So here's our flow chart that we usually get. So you'll have an activity that you'll kind of fill in this flow chart. So please look at this figure. It's in your book as well, and be prepared to do that activity on Moodle. But basically, when we apply our traction force, we get muscle elongation along the spine. And if we have sufficient force, that can potentially improve posture, which all that would decrease muscle spasms. So that's one of our main physiological areas. So these lead up to that. If that force is sufficient, again, we can actually get separation of the vertebral bodies, and that can cause a couple different things to occur. So when we separate the vertebral bodies, that elongates the intervertebral disc, which decreases the pressure on the nucleus pulposa, that pulls in water. It increases the intervertebral space and can decrease pressure on the spinal nerve roots, which could also lead to decreased muscle spasms, as well as decreasing pain. That decreased pressure on the nucleus pulposa can also decrease that disc bulge. So I talked about that in the last video, where that pressure can kind of pull the bulge and center the NP a little bit more. And then that will decrease pressure on the spinal cord or the spinal nerve roots, wherever that bulge was headed, which would also decrease pain. If we separate those vertebral bodies enough, again, usually cervical, we add a little bit of flexion, lumbar, we add a little bit of extension. That can open up our facet joints as well. So not just what happens to the discs, but also to the facet joints. And that can decrease some pro-inflammatory forces, those abnormal pressures, the constriction of the synovial fluid in that area that is causing inflammation. And that will reduce inflammation, which would also decrease pain. And then we can also elongate any scar tissue and maybe joint contractures that have happened in the area, which will help realign those healing tissues and help with tissue repair, which would also lead to decreased pain. So again, when we apply the traction to the spine, depending on if we're talking cervical or if we're talking lumbar, so if we provide about 20 to 25 pounds of resistance, we can get some cervical elongation, separation of the intervertebral spaces of the cervical spine, as well as elongation of the muscles. For lumbar spine elongation, we need about 50% of the body weight. This traction is meant to be relatively short-lived separation. You know, at most, if they're doing sustained with a mechanical, we can maybe get about 45 minutes of them lying there. But for the most part, this is going to be short-lived. That separation really only happens while the traction's on. And so the goal is that if that bit of relief that we get can potentially help break up the pain spasm cycle over the long run, over the course of several treatments, potentially we get some more longer lasting effects. And we're definitely always pairing this with active exercise, other modalities for pain relief and decreased muscle spasm and healing of the tissue. So again, that short-lived separation can hopefully retract the nucleus pulposa. Again, it's not going to stay retract. It will probably go back a couple hours after with weight bearing and movement. But again, repeated use of the traction with some other exercises and modalities can lead to that retraction. You know, the traction can have effect on kind of all the different tissues of our bodies. So it can affect bone in that it can reverse a mobilization-related bone weakness by increasing and maintaining bone density. It can also increase spinal movement, which has a lot to do with the movement of the bone on bone, so especially at the facet joints. For ligaments, it will deform the ligaments, so we get that little pull on the ligament and can increase the movement and decrease impingement problems. At the articular facet joints, we get that increased separation, decompresses the articular cartilage on those facets, allows synovial fluid exchange to get in and nourish that cartilage, and it can hopefully help to decrease degenerative changes that are occurring at the facets and thus pain and the perception of pain in that area. On muscles, it can lengthen tight muscles, allow better muscular blood flow, activate muscle proprioceptors, and all that can help decrease pain and break up the pain spasm cycle. And then in nerves, it can decrease the compression of the forces on those nerves, especially the spinal cord itself or the nerve roots, depending on whether that's stenotic or because of disc herniation or because of muscle contractions or facet joint locks, whatever it might be. So in general, we saw it on the flow chart. We talked about the forces that we need. These are most of the physiological effects that we end up kind of targeting based on the different reasons that we would use traction. So pain relief, increasing the space between the vertebrae, separating the apophyseal joints or the facet joints. That's just another word for facet joints. Widening that intervertebral foramen where the spinal nerve is coming out, removing the pressure and contact forces on any of the injured tissue around, so the ligaments or the bony structures or the nerves, wherever that pressure has been, we can relieve some of that. It increases peripheral circulation, stretches muscles and ligaments, reduces muscle spasms, relaxes those muscles. We get changing intervertebral disc pressure. It will tense what's known as the posterior longitudinal ligament, which runs along the back side of the column that the spinal cord runs through. And so when that tenses, that can help to stabilize the spine as well as, again, kind of help push that nucleus pulposa back into place. It creates that suction, so that low pressure to draw those protruded discs towards the center. We get a flattening of the abnormal lumbar curve, which also provides a sense of traction as well. So when people get that really big lordotic curve, that puts a lot of pain on the facet joints and on the spinal nerves coming out, the nerve roots. And so we can flatten that and make it a little bit more of a normal low lumbar curve. So general uses for cervical and lumbar traction, we get disc protrusions, degenerative disc disease or nerve root compressions, facet joint pathology, and muscle spasms. You can see in this chart kind of which type, intermittent or sustained, is better, and then the position, the angle of pull that we can use for those particular areas. So you'll want to kind of look back at this chart when we start to actually apply this and think about what condition does my patient have, which part of the body am I trying to do, and what position should I potentially put the individual in. So spend some time looking at this chart as well. So indications, it's really about the symptoms. Are they having local or radiating pain, tightness, muscle spasms, weakness in the limbs, decreased deep tendon nerve reflexes on usually singular side, potentially both sides. So we're looking to decrease those type of symptoms. So typical conditions that cause those symptoms, again, disc protrusions, disc or joint hypomobility, compression on the nerve roots, any adhesions or muscle spasms, this disc degeneration, stenosis of the area, contracted connective tissue, so again, joint contractions, those facet joint impingements, and any radiating pain that doesn't improve if we change trunk or neck movement. So again, never used alone, used with exercise, used with other modalities. Finally, our contraindications. Biggest thing is if we don't have a good diagnosis, we don't want to use traction. So usually we don't use it for acute trauma to the neck or the back. If the traction increases any of the radicular pain, so the symptoms going into the arms or the legs, we don't use traction. If we have cancers or infectious diseases, we don't use traction. Again, any uncontrolled hypertension as far as high blood pressure, we don't, especially the cervical tractions, we just don't want to kind of pull in that area. Rheumatoid arthritis or osteoporosis of the bones, we wouldn't want to be pulling on those. Cardiovascular disease, frail older adults, kind of goes along with the osteoporosis. Severe respiratory disease, again, kind of that pressure through the neck can cause it be difficult for the person to breathe and cause a respiratory attack. And any hypermobile vertebrae. So we actually usually on our assessment want to go down and do some spring tests on all the vertebrae of the spine and make sure that none move more than we would expect them to. And if that's the case, we would not want to do traction in that area. So that's our general contraindications for all traction. The ones on the right are specifically for lumbar. If they're pregnant, if they have any hernias, so abdominal or hiatal hernias, we wouldn't want to pull and separate those fibers and the hernia can pop out. If they have active peptic ulcer disease, again, kind of pulling on the abdomen can activate the ulcers. And then glaucoma is especially for our inversion table. If they have, especially with the high blood pressure and any problems with their eyes, we don't want to send them upside down on the inversion table. So again, any unstable spinal segments, any fractures, any dislocations, if something's really severe, like severe disc herniations and things like that, we probably wouldn't use it for as well. Again, any cardiovascular things like vertebral artery dysfunction, that would be for cervical, things like that. Spondylolisthesis, spondylolysis, so again, those stress fractures in the back, we also would not use traction for.